I want to welcome you all to today's presentation in the NNLM series on rural health. This series is running from November 6th through the 21st. I'm Emily Hamster. I'm the Assistant Director for NNLM Region 5, and I'm your host for today's webinar. Okay, so now that we have that out of the way, I want to tell you a little bit about the network of the National Library of Medicine. Next slide, please. The National Institute of Health is the nation's leading medical research agency. The National Library of Medicine is an institute of the NIH. The NLM is the world's largest biomedical library, and it produces information resources like PubMed and clinicaltrials.gov and Medline Plus. The NNLM is the network of the National Library of Medicine. We were established in 1965, and we are the outreach program of the National Library of Medicine. The network operates out of 7 regional medical libraries, often called RMLs, and we offer funding and training opportunities that support equal access to biomedical information. Next slide, please. We have 7 regional offices that make up the NNLM. I'm joining you today from Region 5, and each office is located in an academic medical library that serves that region. Region 5 is hosted at the University of Washington Health Sciences Library. Next slide, please. Our primary work focuses on 3 areas, which include training, network access, and funding. So we offer access to a network of libraries and other organizations through our membership program. And if you have any questions about membership, you can please contact me and I'd be happy to talk with you more about our membership program. We offer free training for libraries and health professionals and the general public, such as this webinar that you're attending today. We also provide funding for health-related projects on information outreach, health equity, and the digital divide. And the program that we're going to be hearing about today, pieces of that program are funded through the NNLM Region 5. Next slide, please. One of the national projects of the NNLM is the Reading Club, and the November selections for the NNLM Reading Club feature 3 titles on rural health. The Reading Club serves to help libraries with health literacy outreach and engagement through reading. It's similar to a book club with club selections and guides on specific health topics. And on the NNLM Reading Club page, you're able to see recommended books by health topic and download a discussion guide and some promotional materials for you. Next slide, please. The NNLM also has a health information guide that accompanies this resource or this rural health series, and you'll be receiving more information about that in the email with the recording for this session. Next slide, please. Okay, so now I'm going to get into today's webinar, which is titled When Your Community is Your Hospital. This webinar is about a partnership between an academic institution and community-based organizations in rural Northern California to improve access to health information for community health workers through a series of trainings. The initial partnership led to further collaborations, and I look forward to hearing more about those collaborations from today's speakers. Our speakers today are Amy Magus, Chico State's Director of Civic Engagement and Associate Professor of Political Science and Criminal Justice, and Heidi Mendenhall, the Executive Director of First 5 Tehama. Patrick Newell, librarian at Chico State, also make great contributions to this presentation, though can't be here today. So Heidi and Amy, please take it away.
All righty. Well, good morning, good afternoon to some of you. We have people from all over the country here, which is really exciting. And I'm grateful to be part of this partnership and then to also get to share this work that we've been doing now for years. Heidi and I were joking earlier. We call ourselves the three of us, Heidi, Patrick, and I. We call ourselves Team Awesome because we just love working together and we love collaborating on this work. And so we're very, very fortunate and grateful that we get to share it with you today and look forward to your questions, your engagement, and maybe potential partnerships in the future as well. So today we are going to be presenting to you When Your Community is Your Hospital, empowering rural community health workers with health information resource education. Importantly, our partnership, and next slide, Heidi, thank you. Importantly, our partnership is a collaboration of several folks. So we want to make sure that we introduce everyone and give you a full sense of who has taken part in this work. So as mentioned before, I'm Dr. Amy Magnus. I'm a professor at California State University, Chico. I am a professor in the Department of Political Science and Criminal Justice. And I'm also the university's Director of Civic Engagement. In collaboration as well as Dr. Patrick Newell, who's also faculty. He's a faculty librarian who does quite a bit of information awareness on campus. And with Heidi, who I'll have introduce herself in just a moment, we are all part of a collaborative on campus called North State Roots. So California's North State, or our rural North State region, we are part of a group that comes together monthly to talk about our region and to talk about what's going on in our region, what resources do we all have that we can marshal to bring together for the benefit of our region. And that is how the three of us met and started to collaborate. And we all realized, wow, we have some pretty serious gaps in health information access, but also in healthcare provider shortages. And so how do we come together to help bridge some of those gaps, given some of the resources that we all have? And so this partnership, again, is very exciting for us. And I'll let Heidi go ahead and introduce herself.
Thank you. Hi, everybody. My name is Heidi Mendenhall, and I'm the Executive Director of First Five Tehama. I did not see so many California folks on the call, so briefly I'll describe that what First Five is in California. It is legislated funds that our whole purpose is to ensure that in our local communities, i.e. our counties, our children and families with 0 to 5-year-olds are thriving. They have what they need for health. And that means the whole child, whole family health with regard to academics, social, emotional, behavioral, and physical. And so for us, we obviously see the health of the community as the health of our children. And so partnering with folks like Amy and Patrick is integral into sustainable health for a long time. So these are kind of our bread and butter in how we look at long-term supports and how we can really provide systems that support our most vulnerable and most influential 0 to 5-year-olds and their young families. Other key partners that we want to mention and are not presenting today, in this work, in this partnership, we work closely with Liz Morris. She not only supported us in thinking about the forming of the framework and how we were going to implement with what resources there were that we could pull into. We were also thinking about long-term resources and how folks who engaged with us in our smaller program could then continue engaging in the NLM resources. And so we actually were able to increase some partnerships and some folks joined the network from this work. And then importantly, Stefania Acosta was our key provider and support in our bicultural and bilingual offerings. And this was something that we could not have done it without. This was a core facet of our belief and our approach was that we were connecting with families who connected with their community health workers and were speaking in Spanish to one another. So therefore we needed to be learning in Spanish and we needed to be thinking through this lens and lived experience lens. And so we were really fortunate to work with Stefania. And then that brought a whole other component to the table of the All About Us or All of Us program, sorry. And so that was another big piece. And that was another identified sustainability factors that we engaged in that long-term research. So these were amazing partners and this is our team. Oops. There we go. So I am going to share our objectives. And so for our short time period today, what we really want to do is share with you kind of our approach, how we identified our why behind what we needed to do for our region. Like Amy mentioned, this happened organically by us coming together. And then we very strategically had these in-depth conversations with the data and the assets that we knew to have. So we're going to talk about that, how we created our plan, how we looked at what our strengths were, and then we're going to talk and share with what we did. Like, what was that? What was our plan? What did we do? And then we're going to share with you both who was better off because of that plan and what we learned because of that implemented plan. So what are key takeaways? Because a key component of this work was not just implementing the program, but doing a research piece of it. We really wanted to be able to glean some research-based understandings that we could then share with folks like all of you, with our very local community partners and community needs, and our both regional and academic community partners, because a very unapologetic component of this work is getting our local universities to be steeped in the reality of all of their community feeders, which isn't always the one that they actually are brick and mortared in, right? And so this is one way that we can get to know and really connect with one another, and that students can be heard and seen in that way. Aim, would you add anything to that, or are you good with those objectives? Good. Okay, solid. All right. So I'm going to ground us in our why. As Amy mentioned, we came to this work very differently, right? So I don't every day visit a college campus. I would love to, but it's 30, 45 minutes away. And so I don't. My work is every day in looking at what programs and sustainable supports we have for young families and children. And so that's kind of what I brought to it. And so this is one of our amazing assets in Tehama County. His name is Uli. In this picture, he's about 3.5 months old. He's now almost 2 years old. And he is our why, right? So we have families and children born every day in Tehama County that don't have access to childcare. They don't have access to healthcare. And so for this particular little boy, his mom was a teen mama. She got pregnant when she was a teen. She spoke Spanish. Her family did not have Medi-Cal services, not because they weren't eligible, right? It's true that they were eligible, but they didn't have them. They didn't have access to them. And so it wasn't until her halfway through her second trimester that she saw any medical attention. And when she did, she really didn't understand, and neither did I, because I was there with her, what she was supposed to do. Like, I got to tell you, I wasn't sure if we were supposed to go to the pharmacy to get the prenatal vitamins, or if she wasn't supposed to take them if they made her sick, or if she was supposed to take them, but only with protein. And it was hard to understand. She got connected with a community health worker who spoke her home language, who identified with some of her life experiences, her life stories, the type of supports that she was experiencing in her small familial community, and everything changed for her. She was able to figure out which appointments she really had to go to and which ones she could miss. She had to figure out like which medicines that were needed and where it was she felt okay with kind of going maybe with what her family messaging wasn't. And she felt strong enough then when she had Uli to continue going to care and continue seeking support. And now she's ended up enrolled in college, and Uli is in a thriving early childcare. So this is our why, right? And I know we all know this, but like grounded with the health and wellness of our youngest population is why we do this work. So that is our why asset. And in that story, I mentioned another asset that we have in Tehama County, and that is our community health workers. We have multiple home visiting programs. So I don't know if any of you on the call, specifically your public health folks, are familiar with home visiting. There's many different models. The few in Tehama County, we use Healthy Families America and Parents as Teachers. And essentially, these are highly educated in child development community health workers. And they provide bilingual, bicultural support to our families that then results in very clear health impact. So on this slide, you see in Tehama County, as compared to California, we have about the same dental visit like percentage, right? Like, it's not great. It's not horrible, but it's not great. If you are enrolled in a home visiting program in Tehama County, you have 20% more likelihood that you have made all of your dental visits, right? So there is like very clear evidence. We knew this asset to be true, that if you could get connected and the community health worker knew what they were supposed to do, you would get there, right? And so this is one of our assets we leaned into. The reason it was so critical for us to lean into that type of an asset is because this program, this home visiting program, they're mobile, they're not brick and mortar, they go to where our families are. And so you can see this picture. We're in Northern California. We're in a part of California that most of California doesn't know exists, right? So a lot of times you hear about San Francisco being in Northern California. We're 4 hours north of that, right? So we are incredibly rural. We're also incredibly widespread. This is not unlike many, many of you, right? So very, very diverse geographic. We have pockets of denser communities and then a lot of miles in between those. And so for families to get to care is very difficult. And that's only when they can actually access it. So Amy will share with you some of that information. We have about, 65,000 residents. We have about the same amount of residents in Tehama County as we do head of cattle at any given time, right? So this also means that when we are anteing up and putting ourselves in line for state and federal funding, we don't always measure up, right? So we have a lot of humans, a lot of children, a lot of families, and not a lot of actual financial assets. So that means we have to lean into what we do have, and what we had was our community health workers. What this slide really shows you is similar to what this slide will show you in a year by year comparison. And that is that we have families who need their basic health needs met. We also have families who are accruing a high amount of adverse childhood experiences, specifically with child abuse, right? And we also see that these are resulting in a need for focused literacy support. So our low third grade SES level, what's not on this slide, is that we also have a really low reading level for all of our adults as well. And so that's a piece here when we talk about literacy and health literacy that you're going to see come up. Okay. So that's kind of who we were. And now I'll hand it over to you, Abe.
Yeah, no, thank you. So Heidi did a really nice job of laying the foundation of the specific case study that we were looking into, right? We're looking at Tehama County. We're really focusing our work in Tehama County for the reasons that Heidi had already mentioned. My job now is to help us all zoom out a little bit and help us understand that for many of us in this room, we're living this experience, right? So this is not a foreign concept to you. To understand that Tehama County is situated in a much larger region, again, of Northern California that's very far north of San Francisco or even Sacramento, and that we as a region are experiencing health information desert, we're experiencing health professional shortages. And with that, many of us who maybe aren't experts in this field, we're not public health officials necessarily. Maybe we don't have the relationships or as strong of relationships with our social service providers as our team does, right? And so for all of us to come together and to think about this health information desert perspective and the health professional shortages is critical for this type of work. So the chart that you're seeing here lays out the foundation for a larger sense of what our region looks like. Now, our region, when we keep referring to our region, we're a region of about 12 counties, give or take if you count maybe some of those closer to Sacramento. 12 counties. We've laid out 5 here for you that we think kind of capture a snapshot of what our region is experiencing more broadly. I would argue that Shasta County and Tehama County are, well, I wouldn't argue it, the numbers say it, right? It's those are the 2 largest populated counties in this list. But then you have some of these other very, very rural, remote counties that we're trying to compare, and all of our counties fall somewhere on this spectrum. Even with Shasta County, which has Redding, if you're familiar with that community, Tehama County has Red Bluff, for example. I'm in Chico, California, which is Butte County, one of the other more populated counties in our region. All of our counties, not just these 5, but all of our counties experience both health professional shortages and the health information desert, right? How do we get access to the information that we need? And then given that information, How do we know whether we need to seek medical care? How do we know whether we need to pursue a doctor of some kind of therapist? And how do we get access to those resources? These are lingering questions, even in 2024, which I know many of you on the call are also experiencing. From the research, we also know that what Northern California is experiencing is not unique to Northern California. I've been doing research in rural communities for almost a decade now, right? And this is what we all know and are living and breathing in our communities. And so we wanted to make that clear for all of you, because while we are focused in California, where our work is focused at the very grassroots level, we hope that all of you can take something away from our presentation and our work and apply it in your own communities in the way that you see fit. Yeah, go ahead. Thank you. So again, we wanted to reiterate the partners in this work because, again, our mission was to really disrupt the barriers to health information access and disrupt the barriers to healthcare professionals. And so with the NNLM and all of us, coupled with this training that we put on around Medline Plus, which is a database. It's a source of information, of medical information that is trustworthy. It's vetted. We wanted to see if we can bring that to our community health workers to then bring to their families that they're working with. Will this make a significant difference in terms of people's feelings of confidence in reaching out for help, in feeling like they know what their next steps should be in terms of medical information, seeking out care? Do they know where to go to even seek out care if it is several hours away? How do we get them connected with those resources? That's a little bit beyond the scope of our specific project, but all of us actually are working on some of that work in addition to this current project. So all of those dots are very connected in this work.
And so we took this, what we knew was our identified need, and we took what we knew from our local identified assets, and then we leaned into those partnerships that Amy just mentioned for the kinds of assets we could implement in our program. And we used this health literacy framework to design a 2 to 3 part learning series that would be open to our local community health workers, home visitors, promotores. We also opened it up to anyone that was like a medical assistant, library technicians, research librarians, anyone that was going to have interaction and communication with families that may have an opportunity to provide some support in health literacy and in helping them to lean into this research-based health information tool. And so while that might look different for all of those different roles, that was really critical. At the heart of this is this kind of idea of health literacy, that you are your own health advocate. And at that point in time, it was 2 years ago, at that point in time, we were constantly inundated with information around our health, and we had to be able to sift through that, right? And then connected is this notion that what's around me in my environment that can support me? Who am I going to that I'm getting individual support to? So this health literacy framework was really powerful, and we used it to design 3 core topic areas. One was simply, how do you navigate through this information? And this was one of the best parts, honestly, for me, was hearing Stefania share about health literacy and digital health literacy. We had a really engaging activity where everybody had to look up toe fungus and what it says on toe fungus, right? And she helped us identify as that we are scrollers, right? That we are scrolling through that information. We are not getting that top level picture or that top piece of information, but we're scrolling through until we find something that is reliable and trustworthy information. And she taught us how to identify that. There were really, really clear tips and tricks. It was incredibly valuable, and I failed to mention this, but these 3 core topic areas were provided in both English and Spanish, and so attendees could register to learn in either English or Spanish. And Stefania was able to provide some lived experiences that were very connective and very real and vibrant. And we could identify with ourselves like, oh yeah, I have that one family member that might give me that kind of different information. And okay, this is a strategy for how I can navigate that conversation. And so these community health worker types, right, promotores, home visitors, and medical assistants, they were like living this themselves and going through this experience themselves. And then we would have that kind of out of body experience where we would think about like, okay, now how are you going to have this conversation with a family or a parent, right? And so they were having this real great experiential learning and then also thinking about how they might navigate this conversation and putting it into their own role. The last and core topic was the Medline Plus and additional National Library resources. This is one of the things that you'll hear when Amy shares about our key learnings was really wonderful. We saw a lot of mileage and people just hungry for a key resource that they could lean into in multiple languages that was easily searchable with nice, great strategies and then practical information about how and when to access a healthcare provider. And so with this kind of sandwich of topics, we were able to really hit everybody that came and everybody gleaned a little bit something different from it. And I think this is also speaks to that kind of magic of the program was that because we all have different lenses, we all got what, everything is always as it should be. We all got what we needed from this work. And that is really what it felt like in this 3-part series. So we had this opportunity to go over these 3 topics. We had a couple in-person opportunities. One was in my hometown in the Red Bluff Tehama County Library, and one was in the Siskiyou County Library. Really have to shout out to these library partnerships. It was so meaningful to have these opportunities in libraries that were open to all community. In fact, both of these libraries have an open door policy. If you're having a community meeting, you can't not invite somebody. And that just made it that much richer. I don't think we did get any walk-ins, but if we had, it would have been lovely and they would have gleaned something from it as well. We extended the conversation with the Zoom review of the information that we'd shared. And then we also rebroadcast that information in Spanish. And we had this opportunity not just for the folks that came in the room, but for different leaders in the communities in the Northwest region as well, so that you could think about, okay, maybe I didn't send somebody, or maybe I did send somebody, and how am I going to connect to these resources? And then lastly, not necessarily in this chronological order, we had an opportunity for folks who came to the in-person training to have a connection and reflect in a very research-oriented focus group and survey so that we could think about what we did and learn from it.
Yeah, thank you, Heidi. And so I think that's one of the most valuable pieces of where we're at now in this process. So we have done the implementation, right? We've been able to put this baby out into the world, and we've been able to make some impact, we think. One of the ways that we've been able to gauge that is through the research process. And so one of the core components of the work that we wanted to do was not just the implementation, as Heidi had mentioned before, but also the research piece. And so all of the in-person attendees completed a survey for us, talking to us a little bit about what they learned, what they gathered, what we could do better as well in terms of the trainings. But then we also had focus groups as well to talk a little bit about how this benefits people's work, how it makes it more efficient. Are we adding something on that maybe they're already doing in a certain way? And so we wanted to get a better sense of that, both quantitatively and qualitatively. And so some of the key research findings we think that are most beneficial really came from the qualitative data, where we were sitting with people, talking with them, trying to better understand what are they really experiencing at the grassroots level, and then how did this training intervene in some kind of important way. So for today, I want to highlight the 5 key findings, right, that we were able to find that there were benefits of Medline Plus as a tool for the community health workers' work. They also identified some drawbacks of the tool and some strategies for overcoming those barriers. So they were really the ones to come to us and say, actually, this is a barrier, this is a drawback, but here's some ways that we could overcome. Again, thinking about rural communities and all of us coming together to marshal resources and lean on each other, that was really helpful. They also talked about the benefits of Medline Plus, the actual training that we provided, opportunities for us to improve the training, and then how the Medline Plus training can be used going forward. For this particular presentation, I want to focus on 3 key findings, which are numbers 1, 3, and 5. And again, focusing on the benefits of the tool, the benefits of the training, and how we are using it going forward. We also have the additional slides for findings 2 and 4 if anybody's interested and would like me to talk through those, but I do want to leave some time for Q&A. So let's talk first about the benefits of Medline Plus as a tool. So the community health workers and other folks in the community who joined us, they really situated their experience in terms of the benefits of this tool and how it's going to change their work. Almost most importantly, I would argue, is that it really does provide access to reliable information for people who maybe aren't as literate in terms of health literacy or even actual reading literacy. This was something that came up in one of the next findings. But having a tool to have valid and legitimate information were the terms that they were using for their families, for people who were in search of this information but didn't know how to find it, didn't know how to vet it, and also didn't know how to use it and take it to the next step. They found that to be extremely valuable. They also identified that the accessible design and how easy Medline Plus is to navigate, both of those contribute to the overall utility of the tool and how accessible it is to the families that they work with. So thinking about the way that the tool is very considerate of literacy, of all different forms of literacy, and not just thinking of it as, a Google Scholar of sorts, but really offering tangible, accessible information and wording so that folks of all literacy levels can access this information in a meaningful way. They also felt like it is helping to reduce feelings of anxiety around medical conditions and information. And I think many of us can relate to this, right? When you don't have access, readily have access to a doctor or a medical professional who could either put your anxieties at ease or help you identify next steps, even taking that first step into looking into a medical condition, whether it's, every time I eat a lot of sugar, I feel faint, right? Like, what might that be? Or, wow, I was already diagnosed with this particular condition, and now I need to be able to find recipes for food that I can eat given my medical condition. This tool helps to relieve some of those feelings of anxiety and helps to break down some of that health information desert experience that many of us are going through in our regions. They also articulated that it makes community health navigator work easier and more efficient. So many of them articulated, I'm doing this work for our families, right? I am the one that's sitting there Googling symptoms or Googling things. And so to be able to share this tool with families and to actually give it to them and have them run with it makes their work a little bit easier. It helps them to empower the families that they're working with as well. And connected to that, it helps families reach their health goals. For many of our families in our region, they are living in multi-generational households. And so for people who are experiencing lots of different kinds of medical conditions, health-related questions, this tool is, it speaks to a lot of different folks. It speaks to, multi-generational households. It speaks to people who speak different languages. So it makes that type of experience much more accessible. Next slide, please. When it comes to the training, back one, Heidi. Thank you. When it comes to the benefits of the training itself, so the tool, right, there were benefits to the tool itself, but then when it comes to the training that we all put on, the community health workers told us that it was very educational and it was helping them to learn how to discern between like safe, legitimate, reliable, accurate information. Again, these are quotes from the folks who participated in the study. And then sales pitches, right? Thinking about the ads that we first see if we Google something and we see those like ads, the sales pitches, versus discerning between that legitimate information. So they felt much more equipped walking away from the training to be able to discern that information. They also felt that the training incorporated a lot of active learning and demonstrations, which made the training both educational and fun. It kept things light. And again, Heidi gave the example of the toe fungus, which gave all of us a chuckle, but it was a really great learning moment for all of us to be able to see the key points that, especially Stefania, who was leading this part of the training, to see how information, can be discerned between legitimate and sales pitch and so forth. So it gave them hands-on training, which allowed them to troubleshoot and use the technology pretty directly, ask questions in real time, ask for guidance, practice with the tool before referring it to families. And so they really felt like they got a hands-on approach to the training. And then finally, which we did not necessarily ask about this, but this came up organically in the qualitative material, was that the community health workers found that the training taking place in a library was really successful. They found that that environment was very welcoming. They find that libraries and librarians to them can serve as information hubs, which interestingly, that is really the core goal of libraries and librarians, right? Are these information experts and hubs, but they felt that having it take place in a library really made it much more community based, as opposed to having it grounded, say, at a university that might have a little bit more of a a disconnect for the general community potentially. And so having it really grounded in the community was beneficial. And then finally, thinking about how are we using this training going forward? So next slide, please. Thank you. One of the things that the community health workers and all of us talked about in the focus groups, and that did also come up in particularly the qualitative data, are the idea of the benefits of multiple exposures. So thinking about working with our families in our region, particularly those who maybe do not speak English as their first language, might be hesitant or reluctant or distrusting of the medical community. How do we help folks understand that Medline Plus is a legitimate resource that they can use that speaks to them and their community? And so for those of us, we were thinking about how do we incorporate multiple exposures of the tool over time throughout our communities and in different spaces. This particular training we put on was a cross section, right? This was a one-time deal, but folks in their own organizations have now taken this tool and tried to embed it and distribute it in different ways. So that leads into the distribution strategies, really thinking at the community level, the organization level, and at the family and individual level, if we can continue to expose both community health workers and the families that we're trying to reach, that this is going to end up making the tool much more accessible for folks and help folks understand that they don't have to now live as much in an information desert, that there are tools and resources, and that they can feel connected through their community health worker to access the next step if they do need to seek out a medical provider. It was expressed that there's a desire for additional trainings like the one that we put on, which was wonderful. Having them in both English and Spanish was a huge success for our community. I would hope that it would be a success in other communities as well, even other languages potentially, depending on your demographics. And then also having virtual options as well as in-person options. So for our region, we're expansive, right? And so we have 12 counties. We have a large service region. And so thinking about a virtual option, one, there's internet, discrepancies, I suppose, in terms of who has access to that. But then thinking about, if we can provide that, how do we then host those trainings in a virtual format in addition to in person? And then for us, building that local infrastructure is key. Helping people understand, talking to them about this tool, helping them understand the state of the problem as well. So thinking about not just what's going on in your local community, but how is it situated in the larger region, in the state? How does that connect to public health dollars? How does that connect to education dollars? I think that that's really the local infrastructure that the community health workers were tapping into, and that we're all now at this stage of the work trying to chip away at and think about a little bit more. So with that, I will end and I will invite questions. We're grateful again to share this work with all of you and happy to share more about the research findings if that's helpful, or any of the other work that we've been doing. So thank you very much.
Thank you, Heidi and Amy. That was great. It's great to hear more about how you're using Medline Plus in your community and the way that your community is working together. For those of you in the audience, please start adding any questions that you have in the chat. And as you do that, I have one question to get us started. So something that I struggle with in my work, and I'm sure many of you in the audience can relate with, is marketing is always a challenge. How did you get the word out about these trainings and Yeah, tell us more about how you got the word out.
Heidi, you start, and then I will build on what you say, because I think for us, it was a very grassroots approach.
Yeah. It really similar. So on one of the research slides, it said, you know, the distribution strategies for community level, organization level, and family individual level. And so I think honestly, marketing was at all three of those levels as well. And because of our diverse partnership, we all have diverse circles. So we were very Tehama centric at the beginning. And First Five Tehama is we are a government entity, but we are a local community-based org for all intents and purposes. And so I would absolutely always promote whatever is happening to be connected to community-based organizations. So whether that is like a local library or like your, you know, local United Way or whomever that is, I think really grounding in that. We then used our connections to all of our partner providers and got it into the hands of all of those community health workers. But at the same time, because we are so steeped in the community, we have direct communication with parents and families as well. And so we didn't discriminate. We didn't think, oh, well, that's our family list or, oh, that's our educator list. We're only going to send it to our healthcare list, right? Because the reality is this information was cross-sectional and embedded in the importance and health of all. And so we sent it to all of our contacts in that way. And then kind of connected to our regional folks and invited them to do the same. And then Amy and Patrick were really integral in the Chico State and that wider network of support and partnership as well.
Yeah, I feel like that captured it. I think a lot of it too is really, you know, I mentioned the regional partnership that we're all part of, that it was sort of the impetus for this partnership to begin with. We reached out to those folks and said, hey, we're doing this work. Are you interested in partnering in some meaningful way? Do you have folks that you think might be interested in attending? And I think through that as well, we got a lot of our folks to come. So it wasn't necessarily through one mechanism. It really did happen both organically through our partnerships, and tried to do it in a grassroots way as well. I saw in the chat some folks are interested in the drawbacks, and I'm happy to go through those slides. Heidi, would you mind just pulling those up? And I think it's, yeah, yep, there you go. Okay, so I mentioned we had 5 key findings. I went through 3 of those. One of the drawbacks of Medline Plus as a tool and strategies for overcoming those barriers, I mentioned that people identified some drawbacks, but then in their own like very grassroots way said, but hold on, there's some ways we can overcome this. They did mention that there was a lot of new information for them when we gave this training, particularly around the tool itself, how it works, how to discern the valid, legitimate information. And so they were communicating that this new information and the tools can be overwhelming for families and community health navigators. And so that was another reason why when we talked about using the training going forward, the multiple distributions was really critical, and the multiple exposures was to give people just practice with this new tool. It's, well, not a new tool, new to them, right? With this tool, to be able to use it effectively, to be able to refer it, and to say to someone, hey, this applies to you. You speak Mandarin, for example. I want to be able to get you the information that you need, or I want to be able to help you experience it in this way. Understanding the nuances of the tool are very important. And so that's more where they were coming from, and that there's a lot of new information. It's really cool. We need more exposure. We need more, there was excitement around it is what I'm trying to say, but that it did feel overwhelming at first. The participants in our training also focused heavily on the need to break down barriers and to meet families where they're at. And so kind of coupled with this tool being new to them, having a lot of information, there was some conversation about how do we navigate pushback or resistance by offering families reasons to use Medline Plus. Again, thinking about this is a legitimate form of information. It's very accessible. You know, it can speak to the needs that you have. You can type in your condition, or you can type in your question and get the information that you need. You can come back to me as a community health worker and get the information that you need, or you know, help with navigating the tool. Again, reintroducing the tool, multiple exposures. So That was one area that they were a little bit concerned about and talking about, well, I anticipate some pushback or resistance, but I don't think it's going to be long lasting. And here's why, and here's how we can overcome that. And then again, returning to the key principles that underlie Medline Plus, so that it does provide the trustworthy information that can help break down the barriers to the health information desert that we're all experiencing in this region. And that the information is constantly vetted, it's up to date, it's a current resource. And so so those were some of the drawbacks that they were seeing in terms of the tool itself, but then also thinking through together in the focus groups, which was really amazing to see. Okay, well, how do you think you could overcome this barrier in your organization? Okay, well, how do you think we could overcome it over here? And really talking out some of those logistics, I thought was really helpful and really beautiful, honestly. And then Heidi, if you could go to the next slide, please. Thank you. And then there was also discussion of opportunities to improve the Medline Plus training itself. And so one of the key barriers that we experienced that we did not anticipate, maybe we should have because we're in a rural region, but we the group, we had asked the group to bring their own technologies. So an iPad, a laptop, a phone that had internet capabilities. But we quickly realized that we probably needed to provide some reliable technology to folks to use during the training. That in and of itself, I think, would have had a much more enriching active learning experience for people because we spent quite a bit of, well, not a ton of time, but we did spend some time trying to help people get on the Wi-Fi, helping people, navigate through different portals and things. And so I think that having some unified technology would have been really helpful, made it more efficient for our group. Additionally, offering some additional examples that encompassed like mental health, dental health, vision health. We focused quite a bit on physical health, which to me encompasses all these other aspects of health. But for folks who were focused on, hey, I work with a lot of people who are trying to get their kid into a pediatric dentist. Like I need to have some examples of that. So expanding some of the examples, emphasizing holistic care, that was a desire from the group and something that I think would have been very easy to incorporate into the model that we were already using, especially around health literacy. But most of our examples were focused on other aspects of physical health. So I think that making the training itself more accessible in that way would have been beneficial for the group.
I just want to add too that several of these folks that came together, that some did work together, but some don't, they come together to other collaboratives and they mention and they share, oh, did you find this? Oh, did you see this? And they have this ongoing conversation. So I think that this finding also alludes to their connectedness and wanting to think together, right? Like they're thinking, I've had this issue with families I'm supporting and I can't find this need. And they want to think with their peers on that. So it's kind of a neat thing.
Yeah, and that reinforces the learning too and broadens it if we can talk to each other to others who are experiencing the same thing that we're experiencing that might be in a different organization. It can give us a new perspective. So I'll highlight a few comments in the chat. One is that it's always tempting to show more, and that's always a challenge for us when we teach Medline Plus. There's so much information in there that you can use that resource in a really, basic way, or you can get all the information you need. And that can be a really big challenge with that resource. I did put in the chat some videos that we have created from Region 5 for community health workers. And these are short tutorials aimed specifically at community health workers on how to use Medline Plus. Right now, those are in English, but we recently got some additional funding to have those translated into Spanish. So Spanish is coming soon on those.
If I could mention something else that this is a terrible oversight on my part, but I also wanted to emphasize we had a couple of students actually involved at certain points, but one of our students, he is a Spanish-speaking student and he came in and helped with translation during the actual training. So Stefania spoke Spanish during our Spanish-speaking trainings, but then we also had a Spanish-speaking student. And he's also a student from the region who grew up in an underserved community in the region. He went to Chico State, and so he was able to lend that very rich lived experience and help the community health workers understand maybe the familial aspect of the work and of the training. And I feel terrible that I didn't mention him before because he was such an integral part of our work and he's wonderful. And so I think just wanted to kind of give that shout out as well, like, incorporating students into the work and helping them understand, how valuable it is to do community-based advocacy and work of this kind through these partnerships. So that was also a valuable partnership with us too.
I just wanted to kind of lean into Priya's comment. So because we're a small community, I actually know some of these positive stories, and not one of our attendees, but one of our attendees works as the family liaison at a local charter school that supports independent study. And there is a family that has parents who signed to communicate. And I actually know that they were using notes and they shared the Medline Plus tool back and forth to communicate about a month or so after the training, just because it's a dear friend that is their teacher. And she mentioned to me at like dinner, hey, did you see this cool new tool? I'm like, I have. So I just thank you for sharing. And I think it's those small moments that can make just the world of difference in feeling seen and having access to information.
See one more comment in the chat from Margaret, my colleague at UW, said that some library workers say that offering more information equals more love. Okay, so as we wrap up, here are the contact information for today's presenters. Thank you so much, Heidi and Amy, for your presentation today, and Patrick as well. We thank him as well.
Thanks for watching. This video was produced by the network of the National Library of Medicine. Select the circular channel icon to subscribe to our channel, or select a video thumbnail to watch another video from the channel.